Okay, so this is our second lecture for our research curriculum. I'm sorry it's a little late. August was tied up with interviews, but so this is building off of our last lecture. This is just going into some things to think about when you're thinking about what type of study design is best to answer your question. And so I'm going to go over briefly, the study design types, which I think most people are familiar with, and less about the actual design of various studies and more about what types of research questions and types of scenarios that type of study design would be good for. So, when you think about, the basic study that we think about, cohort study, that can be, oh, hold on, why is this being weird? My screen just went blank. Can everyone see still?
Now you have like like ultrasound images up.
Oh, hold on. Give me one second.
We could see it before.
Yeah, PowerPoint just like shut down on me. Give me 1 second. Let me restart it. I think I have to share screen again. Oh, no, you can still see my screen, right?
Yeah, we can still see it.
Okay.
Oh, now we see the slides.
So a cohort study, this is what many people have already done, often in residency. So this can be retrospective or prospective. The key thing about a cohort study is that it's an observational study. You're looking at a group of patients with a specific selection criteria that defines the cohort. And with a cohort study, you're looking at an association. And often that's an association between either an exposure, and when I say exposure, that can be a medication exposure, it can be an environmental exposure, or a risk factor. So whether you're looking at maternal morbidity or an ultrasound finding or a lab value, and then the association between those with or without that exposure or risk factor, and then the incidence of your outcome of interest. So some examples of cohort studies that have been done in our fellowship include one of our fellows, a cohort of singletons who present for anatomy ultrasound and looking at the exposure, which in this case was looking at those who got cervical length screening versus did not get cervical length screening, and then the outcome, which was preterm birth. Similarly, you could do like what Dr. Roman has done. So a cohort study, prior to her randomized trial of twins with dilated cervix. And so that's your patient population, comparing the exposure, which is cerclage or no cerclage, and the incidence of your outcome, which is preterm birth. So those are examples of cohort studies. Benefit of a cohort study is that it's generally low cost. Certainly there are very expensive cohort studies that you can do, but for the purposes of fellowship, generally it's a low cost study. There is a limited time commitment. So for a retrospective study, it's usually just the time needed to extract data, which depending on the number of participants you're planning on or sample size you're planning on having, you can decide, is this going to be a 3 to 6 month project or a 1 year project? That being said, you can also very easily do a prospective cohort study in fellowship as well, thinking about doing a 12 to 18 month prospective follow-up of any specific cohort and outcomes. And the benefit of a cohort study, in addition to being able to describe your finding, your association with outcome, et cetera, is that it can often provide rationale for a larger study or a randomized study. The main limitations to remember with a cohort study is that you can only describe association and not causation. And the biggest thing to think about a cohort study is what is really with your patient selection. So when you are looking at this selected cohort and you're comparing one exposure versus lack of that exposure, what are the potential confounders? Because there is likely some baseline difference that would explain why someone got one exposure versus did not receive that exposure. And so you need to think about how you're going to control for those confounders, how those confounders may impact your outcome and how you control for them. That being said, cohort studies are still can be and often are high impact studies and publications that affect management. So, cervical length screening, this was done here. It was done at a few other institutions as well. And ultimately those are all cohort studies, but it's changed guidelines on use of cervical length screening for preterm birth prevention. And then on the other track, Dr. Roman did a cohort study looking at cervical dilation and use of cerclage, and that was the basis for her subsequent randomized trial. So you can see kind of the different impacts and uses for cohort studies. This is examples of other cohort studies for that fellows have done. I just want to again highlight that just because you're not doing a randomized trial doesn't mean that it's not an important or impactful study. A case.
Rupsa,
Oh,
can I give like a 30-second interruption?
yes.
So when I used to teach the research curriculum to the med students and the fellows, one of the things with cohort studies that was really helpful to me, utilizing the Grimes and Schultz clinical research handbook, was the idea of cohort, where that name comes from, that it was actually a group of Roman soldiers, a cohort, and that I literally picture each time that cohort, that a group of people or subjects grouped based on their exposure or risk factor and marching toward outcomes. And that's literally what I picture when I think of the word cohort. It kind of helps me to kind of frame it a little bit, rather than, as we're just about to talk about, the outcomes, grouped by outcomes, and then looking for the comparing the risk factors or exposures. Sorry to interrupt. Thanks.
Thank you. That goes right into case control, which I think people often get confused between the two in describing their study. So a case control, in contrast to cohort study, is you're starting with an outcome and you're looking at cases who have that outcome and controls who do not have that outcome. And then you're comparing the incidence of a risk factor or an exposure. So for example, a lot of the case control studies we see in obstetrics are often, or many that I know about, I guess, are related to, for example, like severe preeclampsia or preterm birth. So cases of preeclampsia, controls without preeclampsia, cases of preterm birth, controls of term deliveries, and then comparing exposure, whether it's, biomarker that you're looking at, whether it's, maternal risk factors, et cetera. But the important thing is you start with the outcome and then you're comparing the prevalence of an exposure or risk factor in people with an outcome versus without an outcome. This is really good for rare outcomes that might require otherwise, years of data collection. So that's why it's something that you often see with like early preterm birth or severe preeclampsia, or things like, fetal anemia, things where you're not going to have many cases per year. It can be low cost, and again, with a limited time commitment, if you have an appropriate time period from which to collect those cases. And just to clarify, a case control study doesn't have to be a rare outcome. It's just a good, it's good for those situations. But you might, for example, be looking at cases of cesarean delivery versus controls without, and that's not a rare outcome at all. But there's a reason that you decided to structure it that way. The main limitation, there's a few things that are limited. So one is you can't describe causation, right? Because you're, again, just defining an association. By definition, it's a retrospective study because you've started off with an outcome. So you're looking back from that outcome. And the biggest thing to keep in mind with a case control study is how you select your controls. So usually there's a specific exposure of interest that you're looking to study. And so you want to have your controls match your cases for as other things beyond that, aside from that exposure of interest, so that you're more able to say, like, look, these cases and controls are similar in all the respects, except, the cases had this genotype and the controls had that genotype. So the more similar your cases and your controls are, aside from your exposure of interest, the greater the strength of your ability to draw a conclusion about it. And there's a lot of different ways that people match cases and controls. Sometimes you just pick, usually not more than 1 to 3 factors to control for. or to match by. So you might say, I'm going to match them by age, everyone, like, and usually maybe an age range rather than an exact year, or match by race, match by parity, so that you have the same number of nulliparous and multiparous cases as you do controls. Like parity, for example, would be an important thing if you're looking at preeclampsia or preterm birth, things where parity is a known, risk factor for having that outcome or not having that outcome. The other way that you can do matching for cases of control is something called propensity score matching, and a propensity score takes a series of factors, and it's usually a way that people match kind of morbidity, overall kind of morbidity. So it looks like age and other BMI, hypertension, et cetera, and you get a propensity score. And that way you have similar kind of morbidity levels, not necessarily the same exact rate of a specific problem like hypertension, but similar morbidity levels between your cases and your controls. So those are ways that you can match your controls. But the trickiest part of a case control design is really how you select the controls. And then it's also, when we're thinking about sample size, you look at, you often with case control, you're looking at, sometimes it's 1-to-1, often you do at least a 2-to-1 case to control. Sometimes you'll do 3 or 4-to-1. And again, it depends. The more matching that you're doing, the greater number of controls to cases that you generally will need. And the greater number of case to control ratio also, again, helps you have more power to filter through the noise and see the, focus on your exposure of interest, because you have, you're not sort of going to be skewed by one control individual being very different than a case, et cetera, or vice versa. The other thing to remember with a case control is that you can only do this kind of retrospective look, looking at the relationship between an outcome and the prevalence of an exposure. You cannot do the reverse. So with a cohort study, you can say, I'm looking at women with diabetes and women without diabetes, and I'm looking at their risk of preeclampsia. And with that study, you will be able to say, like, look, women with the diabetes have a 30% risk of preeclampsia. Women without diabetes, low risk population, has a 10% risk of preeclampsia. Now, if you do the reverse, let's say you're looking at preeclampsia and non-preeclampsia, and you're looking at the incidence of diabetes, you might say, look, women with preeclampsia, 50% of them had diabetes, and women without preeclampsia, only 10% of them had diabetes. So preeclampsia, there's a higher rate of those with diabetes, those with preeclampsia having diabetes. That formulates your next, study design, that maybe diabetes is a risk factor for preeclampsia. But with that case control study, you can't tell me what is the incidence of preeclampsia in women with diabetes. So with a cohort study, you can do a nested case control because you have your exposure and then your outcome. But with a case control study, you can't go back and describe the outcomes that you would get with a cohort study. Moving on to randomized trial, I think this is the type of research most people are familiar with. So it's a prospective, a randomized study is, again, by definition, it's prospective, evaluating the impact of a specific intervention versus another intervention or control. And again, that intervention can be a medication, it can be a management protocol, it doesn't have to be a device or drug. In a patient population with a predefined selection criteria, and you're looking at the effect on a pre-specified primary outcome. And so, a number of examples of randomized trials that we've done here. These are looking at, vaginal versus intramuscular progesterone, cerclage versus no cerclage, inpatient versus outpatient Foley. Those are examples of randomized trials looking at therapeutic intervention. There's also randomized trials, like I said, looking at management protocols. So for example, 1-step versus 2-step for diabetes screening. I know Katie had worked on developing a randomized trial, also looking at management protocols for diabetes. Certainly randomized trials looking at management protocols can become more messy because when you're looking at a management protocol, you want to make sure that all other aspects of management are similar except for your protocol. And that's when things get difficult to do. Versus when you're looking at a therapeutic intervention, usually within the context of a study participant, it's easier to control or limit their therapeutic interventions to what you've decided in your study. So the benefit of a randomized trial is this is really the gold standard way of attributing causation to your intervention of interest. And that's because people receiving that intervention are randomly assigned. And so all other baseline characteristics should be randomly distributed between groups. The limitations, it is more time consuming. So a randomized trial will not be your 3 to 6 month project. It will be, at least 1 year. I'd say usually you should allow 18 to 24 months from start of your trial to completion of your trial. And that's just because regardless of, how long you think it'll take you to recruit patients, there's always delays in getting the study started. You always have to expect hiccups in your initial protocol design or screening or an enrollment plan. And so, realistically plan for 18 months for a study. It can be costly. The way that you do a randomized trial without funding is that you look at non-experimental interventions. So things that are otherwise within standard of care. And honestly, that's a lot of the questions that we have. We have multiple options for standard of care. It's unclear which one is best. So what do we do? And so most fellow randomized trial research studies involve comparisons of interventions that are all within a standard of care. So it's not exploring a new drug therapy or an expensive drug therapy. It's comparing standard of care to answer, common clinical management questions. The other ways to keep costs down in a randomized trial and, feasibly do them in fellowship is number one, think about how many participants you're aiming to enroll, the number of cases participants we have, so who meets inclusion criteria for your study at Jefferson and our associated institutions. And then, thinking about your outcome. So if you're looking at an outcome that involves lab or blood draws, then that's something that you would apply for the fellow research fund for versus, again, a clinical outcome or something that is done routinely where you don't need any kind of funding to look at that. And then as with everything, garbage in is garbage out. So if you start off with, significant selection bias in how you're enrolling people, like, when you decide to screen someone from enrollment, biases you against a, significant population, or if you have not designed your data collection in a way that's, clinically applicable, or in a way that can be analyzed the way that you're planning to, that's not something you want to figure out, at the end of your study. So those are things that you need to think about early on. And, a lot of time, I think, goes into your thinking about power calculation and which outcome to choose. And that's all very important. And those are the first things to figure out. But just as much time needs to be going into what is your specific inclusion and exclusion criteria. Because again, you can be at the end of your trial and realize, you know what, I never excluded placenta previa or accreta, and all of those patients are getting, a 34 to 36 week delivery. And how does this impact my outcome of, whatever term outcome you're looking at, et cetera. And so you need to put just as much time into thinking who you're including, to make sure you're including the right population, and also who you're excluding, because the more things that you exclude, it might make your conclusion cleaner, but the payoff for that is then you're limiting your external validity. So if you do a study only in nulliparous patients, that's great. You're excluding this, significant change in outcomes that we see with multiparous patients, but also then that data is not applicable to multiparous patients. So, after you've decided your sample size and your power, you really need to put just as much time into your inclusion exclusion. And then the second part of that is you need to is thinking very carefully about screening and enrollment. it's something that when you read a paper, there's maybe one sentence about screening and enrollment, but actually when you're doing a trial, often most of your work is in screening and enrollment. And so having a plan in advance and then a backup plan for that plan is important when you're thinking about design of a randomized trial. Systematic review and meta-analysis. So this is a review of existing studies, which can be randomized or observational. If you're just doing a systematic review, it's not necessary. Often that's looking at outcomes related to a specific condition, plus or minus a specific intervention. If you're doing a meta-analysis, often you're comparing one intervention versus another intervention or control in a group of patients with a specific condition. So similar kind of setup to what a randomized trial is, having intervention versus non-intervention and looking at outcomes. And the benefits of it are that you're not doing a randomized trial, right? The trials are already done, you're collecting the data. It's still, a high, potentially high impact publication because you are collecting a lot of data, and therefore you have more power to look at efficacy, outcomes, and safety. There's a lot of examples of systematic reviews and meta-analysis. Obviously Cochrane is big in doing this, and most national, international organizations, often their recommendations will first come from a systematic review and meta-analysis data, and then go to individual trial data. So benefits are it's low cost. You may or may not need statistical support, but importantly, our librarian or our library, there's not a specific librarian, but our library does have a means for you to sort of consult with them, and they will help you design a search strategy. That is, again, one of the most important parts of a systematic review, because garbage in is garbage out, right? So if you don't design an appropriate search strategy, everything else after that is not going to be correct, including the studies that you identify and include. And so Scott Memorial Library is great because they do provide assistance in doing that, and for the major from at least 3 major databases. I call it an intermediate time commitment. I say intermediate because sometimes it can be quick if you're doing a smaller one. But I think if you haven't done a systematic review before, it's easy to underestimate the upfront time that you put in. Just like, with a randomized trial where the screening and enrollment is one sentence, but actually when you find yourself doing the trial, that is the majority of your work. With a systematic review, the search, it can end up being the most time consuming. The search and selection of articles is usually actually the most time consuming part. And so I do say usually allow, 3 months for a systematic review or meta-analysis, 3 to 6 months. If you're doing a large one, certainly it can take longer than that. And then certainly if you're doing an IPD where you're requesting data, individual patient data from trials, that is going to be a 12-month endeavor, just because of the time it takes to get that data, clean it up, and analyze it. Like I said, big benefits are it increases the power to detect significant differences in primary and secondary outcomes. So looking across multiple clinically relevant outcomes, as well as rarer things like safety. And it's also a great way to do subgroup analyses. So often individual trials are not powered to detect differences in subgroups, although they may have planned subgroup analyses. But when you combine trial data, you are able to get enough patients with, a cervical length less than 10 to see if vaginal progesterone is effective in that smaller population. And that's thinking about meta-analysis, looking at a systematic review of not looking at an intervention, but why would you do a systematic review is it's good for rare conditions where there are few studies. And so in this case, you could compile, several different case series to look at, the management of women with a prior stroke in pregnancy. It's something that's not very common, and you can compile outcomes that you get from case series to help clinicians think more about what are the outcomes and interventions used in this population.
Rupsa, this applies a lot for the genetic disorders in pregnancy.
Yes, exactly.
Like, our OTC review is making a big difference, which is ornithine transcarbamylase deficiency, X-linked disorder. And I remember I had a Persian physician. She worked almost like more than, maybe a year or two to finish it up. But it makes a big difference. We're working on another one for porphyria in pregnancy. We're working on another one for Al-Chad in pregnancy. But these are things I started from before. I haven't had time to finish them up, like 2 to 3 years in the make now. So, but basically these are genetic disorders, and basically, there's no way except by pulling up these case reports. Yep.
Yeah, and I think, and I say that to highlight that I don't want you to get sort of pigeonholed into thinking systematic review is always a meta-analysis and is always comparing, compiling trial data. So
Yeah.
a lot of systematic reviews are not, and it's again, just being able to provide what is the incidence of outcomes, in these rare conditions, or what are the therapies being used and which patients are getting which therapies for rare conditions where otherwise people are kind of at a loss. And there aren't clear guidelines. And then
can I ask a question? Is there, when you combine, and like if you were to do a review of both RCTs and observational studies, does that dilute the significance of your findings? That's one question.
Yeah, so usually you don't combine it does dilute it, and then all of it ends up being the same as observational quality, because as soon as you mix randomized trial data with observational data, it all becomes the same as observational data. So usually, unless there's something, so it does affect the sort of level of evidence. If there's enough randomized trials, usually you focus on randomized trials. If you're going to look at both, because there's not a lot of studies in that area, you might combine them, but then also analyze randomized data separately, just to get, what does the randomized data say on this topic. Randomized trial data is always going to be superior sort of quality of evidence to observational data. And so that is, if you have randomized trial data and enough, studies, not just one where you're not really able to do a meta-analysis on it, then you might, then you'll exclude observational studies. You might, for example, if it's something rare, you might plan, and like with all studies, you make an a priori plan. And so you might say, if there are more than five or more RCTs found, we will restrict the study to randomized trials. If there are less than 5 RCT found, we'll look at randomized trials and observational with a planned subgroup analysis on just randomized studies, like something like that.
And does the number of positive, let's say randomized trials matter? Like, can you have a meta-analysis and all were negative?
Yeah.
No difference, and then or do you want to generally do when you have 3 or 4 or 5? Does that matter?
So you don't really get to pick what you find in as far as how many trials are positive or negative. Part of the analysis you do in a meta-analysis is like a forest plot to see the scatter of how many positive or negative trials you have, and that's to help with publication bias. That's useful only if you have a larger number of trials. The other thing that you'll so the answer is like, no, there's not like a pre-specified goal for positive and negative trials, because you don't know what you're going to find, that and you shouldn't know what you're going to find before you embark on the systematic review. So the quality of your systematic review and meta-analysis will not be judged on whether the studies identified were positive or negative. It would be judged on the quality of your methodology going into it, and significance of your review, etc.
Let me reinforce a couple of things that Rupsa said, Mori. So the editorial boards I'm in usually use 2 or 3 randomized studies. So if there are 2 or 3 randomized studies that you're hopefully excellent search identified, they're not going to like that you added on 5 or 10 or more observational studies that are good. They're most of the time going to send it back and say, even if there's 2 or 3 randomized trials and they're not terrible and they're not 10 patients each, just do the randomized trials. If there's only one randomized study, it's not that great. I think, some editorial boards let that go and accept the meta-analysis. And why do you use magnesium for neuroprotection? What's the evidence for that? It's pertinent to this talk.
Like what you mean, like what are the trials that evaluated it?
Right, so the 5 trials
So-
that looked at that, they're negative.
Well, wasn't the BEAM trial positive for among surviving newborns?
No, the primary outcome was negative. Russ will tell you that. It was a negative trial. NIH are very strict, negative trial.
And the Australia was negative, right? Too.
Right. Some 2 biggest, better ones. So you use it because of the meta-analysis showing CP. It's, decreased by half. So that's a good example of what you just asked. Sometimes you have a bunch of negative trials and then you have a positive results that changes practice.
Well, great.
And along those lines, so again, meta-analysis certainly has the potential to change clinical guidelines and care for exactly that reason. Oh, sorry, this keeps freezing. Can you still see my screen?
Yeah.
Okay. So the main things to think about with a systematic review are number 1, publication bias. And this is something that when you're evaluating the quality of your review and the quality of your data obtained, you will comment on publication bias. The biggest thing I always like to highlight with a meta-analysis or a systematic review is thinking about the heterogeneity between studies. So what is the difference between the inclusion and exclusion criteria? What is the difference in the time that studies were done? So I had reviewed a meta-analysis on, I can't even remember what the intervention was, but basically the studies with, and it was observational, so that was a problem to begin with. But the studies that had one criteria, basically many were after a certain time point versus another where many of them were before, and it was looking at neonatal outcomes. So of course, the timing of your publication of a study, when you're looking at something like neonatal outcomes, that makes a difference, and it may not be clinically relevant to you. What was a difference in neonatal outcomes in like low middle income countries, because you're focused on what would be an impact here in the US, and if they're not resuscitating less than 28 weeks, that's not relevant for your question. So those are things to think about when you're thinking about what you're going to include, or if you've decided to include everything, how you're going to draw your conclusions. So for example, the USPSTF, many of, again, like national societies, their guidelines are often driven by meta-analyses. They do their own meta-analyses, and their meta-analyses are restricted to high income countries. So, they use a economic indicator to select countries from which they will include trials from. And that's because they are looking to apply data to a US population. And so they're looking to include studies in similar populations. And then a big thing that comes up is definition of outcomes. So you might have a very specific outcome that you're interested in, a neonatal outcome at 6 weeks or 6 months, or a hemoglobin at a certain time point. But the less kind of common that outcome is, the more difficulty you might find in having studies that all are looking at that outcome of interest. So for example, most pregnancy-related studies will have gestational age of delivery, which is a set time point, or they might have mode of delivery, C-section versus vaginal delivery. But then let's say you're looking at preterm birth, and some studies might define preterm birth as less than 37 weeks. Some might define preterm birth as less than 34 weeks, or maybe you're looking at anemia, and some studies define anemia as a hemoglobin less than 11, and some say restricted their anemia to a hemoglobin less than 8. So those things, affect what patients were included in those studies. And if there is a lot of difference in your study's inclusion and exclusion criteria, those are things you think about when you're interpreting your results. if there's a lot of variation in how outcome is defined, there's nothing you can do about it. Again, you report your meta-analysis, it just limits your ability, it can limit your ability to do a meta-analysis. And so again, because you're deciding your outcomes in advance, pick a few different outcomes. You'll have your primary outcome, but pick some other ones. Like let's say you'll look at you're interested in preterm birth less than 34 weeks. Okay, but also look at preterm birth less than 37 weeks and less than 32 weeks, so that if you don't get a lot of study data with your outcome of interest, at least you have these other outcomes that the studies might have used instead. So those are ways to work around that. But again, just like with any study, these need to be defined in advance. So when you're doing a systematic review, as we talked about before, you register that in Prospero. So you register all your outcomes in Prospero. You don't collect a lot of study data and then pick which outcomes you want to look at or which one you want to do for your primary outcome. Moving on to cost-effective analysis. So this is along the lines of a systematic review. This is,
One
yeah.
question. Are you including the IPD meta-analysis in your review?
I didn't make a separate slide on it, no.
Just to make a comment about that is, I mean, based on the limitations you just mentioned, the best way to correct those limitations is to do IPD meta-analysis. And I think this personally, I think is the superior study where you finally bring all databases together so you can control for the different demographics. And then by combining the databases, you are now able to produce new data that cannot be identified by looking at the paper alone.
I 100% agree. I like 1,000% agree. Yeah.
Thank you.
I think it's very true. You know, that is my problem with meta-analyses. And
the clear example is twins, short cervix or clash, where by looking at the data alone, it looked like it will be increased risk of preterm birth or clash. But when you look at the actual IPD meta-analysis, where the demographics were corrected, now the outcome is completely different. And now it says clash did not increase it. It didn't improve it, but at least it didn't increase the risk of preterm birth. And what it means, you need a larger sample size. So studies like that, when you look at an IPD meta-analysis in aspirin and prevention of preeclampsia and chronic hypertension, things like that, there are multiple of studies like this, and they're far superior than anything else. I mean, they're as close as an RCT, as an independent data.
I completely agree. The other thing I didn't mention in heterogeneity between studies is actually dosing and formulation of a medication or surgical technique if you're looking at a surgery. So, you know, when you look at meta-analyses on aspirin or progesterone, you know, those studies, there was different doses used, there's different formulations used, there's different timing of when that intervention was done. And so, again, going into the design, either if you know going into it that this is an area with a lot of heterogeneity, you might decide, I want to do an IPD and this is how I'm going to design it. If that is, like I mentioned, if you're doing an IPD, that is a 12-month minimum type of study timeline because of the time it takes to request data from people and then actually clean it up so you can use it for your own analysis. But the other way to address heterogeneity within studies is doing planned sensitivity analyses. So you might say, I'm including all these studies, but we'll do a sensitivity analysis based on gestational age of enrollment, you know, being in the first trimester, or, you know, certain subgroup population that you're looking at. You might do a subgroup analysis in that population. So there are ways that you can do a systematic, a meta-analysis without IPD and still try to address those heterogeneity questions. Again, though, all planned in advance. So cost-effective analysis is along the lines of a systematic review. It's using existing literature data, and so you're not collecting data. A cost-effectiveness analysis does not establish efficacy. So the goal of a CE analysis is not to establish efficacy, but to evaluate the relative cost of an intervention and the cost or cost savings of the benefit. So for example, cervical link screening and preterm birth prevention, how much does it cost to do 100 ultrasounds to identify 2 short cervix? And then how much is the neonatal cost for those 2 24-week preterm births that you might have prevented? So along those lines. These are often secondary analyses on randomized trials or on meta-analysis data. You have, it's low cost because you have data already collected. Again, just like with a meta-analysis, garbage in is garbage out. And so usually, so for a cost-effective analysis, you need to know the rate of your outcomes with or without your intervention that you're studying. And you need to know the costs associated with that outcome or cost savings associated with not having that outcome. And so there are limitations to a cost-effectiveness analysis because it's really based on available data. So for example, if you only have one randomized trial showing the rate of an outcome with or without an intervention, the strength of your CE, if it's a small trial, might be limited because you only have sort of one reference for what is the rate of this outcome. The other things to keep in mind is costs. Usually that's found based on, here in the US, like published, Medicaid costs you might use or Medicare costs. And so it's, it's an inexact science. Our School of Population Health has many graduate students who are working sort of in these economic analyses. And I think if you have no experience in it, it's worthwhile pairing up with someone in population health because it's a very different type of analysis that you do. And so, often like graduate students in population health, they might not have the clinical knowledge to know what is a clinically relevant cost effectiveness question, but they have the tools to answer that question. And so it's a great opportunity for partnership. Implementation research is another common type of both resident and fellow research project. It's looking at the feasibility, acceptability, adoption, cost, sustainability. So it's pretty broad. Not that it looks at all of those things. It can look at any one of those things of an intervention that's demonstrated to be effective. And so you're not testing the efficacy of an intervention. You are examining how is it, being used in real world practice or what are barriers to use in real world practice. So examples of implementation research, that we've done here, evaluating the rate of aspirin prescription or aspirin use following a new guideline on preeclampsia. So we, this was before the most recent update, but we did a prospective study looking at how many people with risk factors for preeclampsia were getting aspirin, and then a survey looking at what are barriers to patient perceived barriers to using aspirin. Another example is use of vaginal prep prior to cesarean section. So again, you have a new guideline that comes up that tells you that this vaginal prep is useful in preventing infection. And so the question isn't, is our infection rate reduced? The question is, are we using this appropriately and what are the barriers to it being used? The benefits are that it can be retrospective or prospective. It's generally low cost. It almost universally does not require patient consent unless part of your implementation research is doing sort of patient-based surveys or interviews. Limitations are you're not establishing causation because by definition, this is usually an observational study, although you could study the implementation of a protocol. But again, then you're going back to it being potentially a randomized trial or a cohort study looking at a specific intervention. So you're looking at the effect of that. The main thing with statistical considerations is when you're comparing pre and post outcomes, often this is based all over time because you're looking at implementation. And so you might have to think about how trends over time are accounted for in your analysis. Population-based research. This is great and can often be a short or intermediate term project because you're using existing population data sets, so it does not require prospective collection. It is little or no cost, so many data sets are freely available. Some you do have to pay for. Some we might already have access to, but if not, it's a great use of the Fellow Research Fund, and generally cost for databases access is well within what we would be funding with our Fellow Research Fund. And then, like I said, these are often great 3 to 6 month projects or 6 to 12 month projects. The biggest limitation being the time it takes to extract your data of interest. Then I'll show you sort of what that looks like in a minute. The limitations is that you're not able to evaluate baseline characteristics or outcomes beyond what has already been collected. So these are established sets of de-identified data, and you get what you get. And along those lines, there's always potential misclassification based on coding. This is really important when you're looking at timing and looking at things like maternal mortality, because that might have been defined differently in 1990 than it was in 2010. So those are things that you need to think about. Or viability might have been defined differently. So, and then accuracy of data collection is not something you have control over, but it would be a limitation in that study type. There are a lot of sources available for population data sets, and I just put a few here so you kind of get the breadth of what you can look at. So National Center for Health Statistics or Vital Health Statistics, so US birth data. National Inpatient Sample is sort of all hospitalizations, and it's ICD-10 code based. There's CDC Wonder, which is, as described, wide-ranging online data for epidemiologic research. It includes a collection of over 20 US-based data sets, including, and I just picked some that were relevant here, data sets relating to births, deaths, and maternal mortality. There is a pregnancy risk assessment monitoring system, which is state-specific maternal data. And then I wanted to highlight some things that you might not think about because they don't jump out as immediately pregnancy related, but NHANES is National Health and Nutrition Examination Survey. That includes pregnancy data. And so if you're looking at things like nutrition and pregnancy outcomes, that's a great source. There's a national survey of family growth. Again, that includes reproductive health and pregnancy data. And of course, national vital statistics. I put this website here, the SMFM website has a long list of publicly available data sets, which may or may not require payment, but it's a long list. I just selected some here. The biggest things with population research is there's some important statistical considerations. So when you're doing a population-based data set, that's observational data, that's not randomized trial data. So there's going to be bias in that you have to adjust for. So if you're looking at either association of a risk factor with an outcome or association of an outcome with a risk factor, you might do propensity scoring or other types of adjusted analyses in order to correct for those baseline differences that you will see between your groups. The other thing is with this type of population data set, there will often be missing data. And so you have to decide how you're going to address that missing data in order to include, which affects like what you end up including in your final analysis. So this was a study done by a group including fellows and trainees here and in Italy, but this was looking at the impact of labor at 39 weeks on the incidence of stillbirth. The point of this is not for you to think about what the actual question was, but I want to highlight sort of the steps that go into taking data out of a population data set. So this was US vital statistics data. So they evaluated, they started off with 12 million births and 150,000 stillbirths. And so the work in doing a population data set analysis is in sort of cleaning this up and getting to your population that you're including, your exposure of interest versus your control, and then getting into what and then, you might exclude, so here unknown, where you have missing data, some of that might be a reason for excluding those cases or participants from your data set. And so this is really where the work goes in, because your ability to draw conclusions from your data really depends on what this workflow is, and the biases that you might have in your conclusions and your results are largely determined by how you do this kind of flow chart to get to what your final inclusion is, what you're comparing, and then how you're controlling or adjusting for confounders. Similarly,
And I put a plug for Emily Rupsa, our former fellow here, Emily now at Temple, really is a maven at this, if you guys need help. Just yesterday we had a call. We're going to try to look at national data for the last maybe 2 or 3 decades for birth weights, to look at birth weight trends. And so she's going to look at one of those databases, from the CDC, et cetera, and wonder. So if a fellow's interested, more than welcome to join. But she's really helpful, and she's a great teacher. So she could certainly pass those skills along. She's an MPH, and I think she somewhat came with those skills and then, I guess, mastered them while she was here with Rupsa and everybody else.
and along those lines, these data sets, as you can see from starting with a data set of 12 million, can be unwieldy. And so it's really helpful, to work with a mentor like Emily Oliver. I know Rodney's done some population data work as well, who are familiar with that specific data set, whether they have the outcome that you're looking for or the coding of the risk factors that you're looking for. But you'd be surprised. There's a lot of, detail collected, like, whether it was a prior C-section or not, or more than one prior C-section, or if there was a there's a lot of maternal history that does end up being put in there, including things like prior preterm birth, prior demise, things like that. Obviously the basic things like parity, but so it's great to work with someone who's familiar with these databases and can direct you to the one that has the information that you need and also can help you work through it. I put secondary analysis of existing trials because this is similar to the population data sets. So no additional data collection. It's generally you're receiving de-identified data. So it's IRB exempt, there's no patient consent. And then similarly, you're limited to what has been already collected in that trial. So you're unable to evaluate any additional characteristics or outcomes beyond what was collected. The main point to think about when you're doing a secondary analysis of a trial is you have to think about who was included in that trial. Was there selection bias? Because often your research question in your secondary analysis may not be, it might not even be related to what the outcome was that they were looking at, or the study population that they were looking at. You might have something completely unrelated, but you can study it with that study group. So thinking about the population that was included and how that impacts your secondary analysis. This is really important, especially for large randomized trials where there is, often a pretty detailed screening and enrollment. So maybe it only includes people who have presented in the first trimester. And so it's limited to, patients who present for care in the first trimester, things like that. There are some great existing databases for secondary analysis. So NICHD has, it's called DASH, it's Data and Specimen Hub. You can request de-identified data that's free for NICHD studies. Usually it's not studies that were completed in the past year, but I don't know if it's 1 year or a few years, but whatever what the cutoff is for when they have to make that data available. But you can go online and see what studies are there. So for example, late preterm steroids, low dose aspirin, the prevention of preeclampsia, and then older studies, genome-wide association study for preterm birth, so those are, trials. And then there's also observational studies like nulliparous pregnancy cohort and outcome, consortium on safe flavor. There was a cesarean registry. So there are large trials as well as large cohort databases, all de-identified, anything with the NICHD, it will be free of cost for access to that data. You just have to, you go online to their DASH website, you basically request it. The DASH website also allows you to look at the forms, the data forms used in the study. So you can go through the data collection forms to see if they have the, maybe you're looking for a specific, you're looking for, whether a woman with a prior D&E or not had whatever outcome in this cohort. So you can go back and look, and did the nulliparous pregnancy cohort include prior D&E or not? So you can actually look at what the data forms are, so you know what data was collected and how it was collected, and then you can request access to that. The important thing to keep in mind, and you can identify this by the study, is that these are publicly available. So there are many secondary analyses that have been done using these data sets. That doesn't mean that there isn't more to do. I just want you to be aware. And when you're looking at any individual study, you can see the associated publications from that study. Also important to keep in mind that we have existing databases at Jefferson of completed trials. So VIP, which is recently completed, MODE, which Lean so VIP was our progesterone trial. So it's a population of patients, singletons with prior preterm birth. MODE, which was looking at induction of interventions relating mode of induction of labor in high-risk singletons, and then POPS and POPT, which was looking at pessary and singletons and twins. So these are all studies that we led or were part of, and so you could have access to those databases. Just to give you an example of some publications from secondary analyses, again, this was from a group of fellows here. And actually, this might have been Emily's residency project that she carried forward. But this was using the NICHD C-section database. And again, that was a large cohort study. And so you could look at a number of different specific questions. This is prior classical incision. You could look at, abdominal cerclage. You could look at prior myomectomy. So you could look at something completely unrelated, like, a maternal risk factor. So a lot of different ways to slice that cake. And then that one below is a secondary analysis of a randomized trial. And I bring this up. So this was a study looking at the use of pessary and singletons with short cervix. So the reason I like to bring this up is the secondary analysis was looking at how the relationship between cervical length and cervical dilation at the time of the cervical length. So this secondary analysis had nothing to do with the intervention and had nothing to do with the outcome that was studied. But it was using the baseline characteristic information that was collected as part of the study to look at the relationship between two different baseline characteristic factors. So I highlight that again, just to have you think outside the box. Don't be restricted by what the study title is. Instead, think about what the study population is. And is that a population that you're interested in studying?